Good morning, Bob. Thank you so much for meeting with me this morning again.
Good morning, Tammy. Nice to see you again. We had, as always, a wonderful turnout on Friday at the gym,
Yeah.
and a whole host of great questions on a great topic.
Yeah, absolutely. So, to get started, our topic, we had a Power with Parkinson's get together, a potluck, in fact, and it's just so much fun to see people interacting and building friendships through this. And the topic we talked about, which before we say it, um, the one thing that was resounding afterwards was the conversation of it's good to know that I'm not the only one dealing with this. And
Yeah,
and it's a subject that people probably aren't going to walk out of their house, walk into the gym and say, "Hey, I've got this." And so the subject is urinary control, bladder control or lack of control that
yeah,
is very typical with Parkinson's. So answer this. Why? Why is it typical with Parkinson's, Bob?
sure. So, you know, a- about 65% of patients with Parkinson's will present at some time with a urinary issue. And there are many urinary tract issues. The one we kind of spent the most time on was the overactive bladder, referred to as OAB, overactive bladder. This is by far the most common of all the so-called urinary tract issues that do occur in Parkinson's. And actually, in Parkinson's, they refer to an overactive bladder as a neurogenic bladder. And the reason why they do that is by adding that neurogenic term in there, it tells us that there's nerve involvement here.
Hmm.
And it's a wiring issue. That's the problem here. And of course, we all know the role of dopamine and what it plays in Parkinson's. And a lot of the things that are under the control of our autonomic nervous system are they're under attack in Parkinson's because of these lack of dopamine and the fluctuations of dopamine that they get throughout the day. Unlike you and I, for instance, we would have a steady state level of dopamine being manufactured and secreted all day long. They don't have that. They've got these peaks and valleys that occur, and that plays havoc on the autonomic nervous system. And the bladder is directly under the control of that autonomic nervous system. So that doesn't mean even non-Parkinson's patients can have an overactive bladder. Just simply, if you live long enough and you're old enough, at some point in time, you will have a bladder issue. And that's just the way it happens. It's just age plays a huge role. But in Parkinson's, it's that double whammy. It's a disease of an older population. So they've got that going against them, plus the Parkinson's. So it's kind of a double whammy for them. And it affects the quality of life for a lot of patients.
Yeah.
It does have ramifications just outside of the bathroom, for instance.
Right. Right. And we've had these conversations before about just even while you're sleeping, and how unpleasant it is for to wake up and realize you've had an accident, so to speak, or for your partner.
Yeah,
And so dignity plays a role in that. Nobody, no strong
absolutely.
man who's lived a long life and provided for his wife wants that to happen. And so, but the beauty is this, as we bring this community together, as we educate them and also ourselves, you know, um, it's really, there's no shame involved. This is just
No,
unfortunate.
and there
Oh,
shouldn't be. It's
mhm.
part of what we sometimes refer to as the non-motor symptoms. Like often to call them the invisible symptoms.
Yeah,
Very often you look at a PD patient and we're all expecting to see the slowness, stiffness, tremor, and instability, postural instability. But it's hard to look at what and say, oh, that person's suffering from depression or anxiety or cognitive issues or urinary tract issues. These are all the invisible things that you don't see surfacely, but they're there for a lot of them. Like I say,
yeah,
probably 60, 70% of them at some point in time has
yeah,
some issues. And the issues vary. I mean, we're only focusing just on the overactive bladder, but there are urinary tract infections that occur very
oh
commonly
yeah,
in them, right? Urinary retention, hesitancy, these are all things that can occur. And we have treatments for them. I'm focusing mostly on the medication end of it. And we spoke about a few of them the other day. But
Yeah.
this is very common, and it needs to, people need to understand that it's part of it. There's no disgrace in talking about it, and they shouldn't be shameful about it. People can have, it can have a huge psychological effect on both the patient and the caregiver. They lose self-esteem in themselves. They're concerned about being a burden on their family. They're concerned about odor issues,
Yeah.
intimacy. I mean, everything changes because of it. So even the simplest of symptoms can have an impact on the quality of their life.
Right, right, absolutely. And so you just alluded that there are, there are drugs that are, there's a common category of drugs. So let's talk about the common category of drugs first, and then we'll proceed to the super drug, or the one that seems
Yeah.
to be true.
So, like I said earlier, the bladder is under the control of the autonomic nervous system.
Mhm.
And one of the ways its function, it has two functions. One is to store the urine, and the other function is to void it or get rid of it at some point in time when it's reached its capacity. Um, and it's under the control of, it has cholinergic receptors. These receptors in our nervous system cause the bladder to prematurely contract when they're stimulated. The mindset back in the late 90s, early 2000s were, once they understood how the nervous system impacted the bladder, and understood that there were cholinergic receptors that respond to a specific type of neurotransmitter called acetylcholine. Once they understood that, then their mindset was, well, if that's a cholinergic nerve that causes it to contract, suppose we developed an anticholinergic drug that made it relax. And so they ran with that. And between, I guess, maybe around 1998 and the early 2000s, there was an onslaught of drugs that came onto the market, about six of them altogether, of this class called anticholinergics. And quite frankly, they worked really, really well. But that doesn't necessarily mean that they were the best choice for Parkinson's. And this was one of the reasons why I came up with this topic to discuss Friday, was because I've gotten questions about, is there a drug that's specific for a Parkinson's patient who is suffering from an overactive bladder? Or do they just have to use the everyday ones that are out there for the general population? Sadly, we do not have one that's designed only for Parkinson's patients. We do have to share the wealth with the general
Mhm.
population as far as all of theirs that they have.
Mhm.
And there are six of them that are out there. Probably, if you have overactive bladder issues, you're probably more than likely going to be on one of those six. Um, Danafenicin, solifenicin, um, testoterodine, fesoterodine, um, oxybutynin, and trospium. These are the six most commonly prescribed that you would see. They do have brand names, but honestly, you're never going to see them. They haven't been around, the brand names, because these drugs have been around for almost 2 decades. And they have, any drug that lasts that long, in most cases, it has a proven track record. It has a safety profile and an efficacy profile. That's pretty good, but that doesn't make it right for every Parkinson's patient. And the problem being with using this class of drugs, anticholinergics, is mostly their side effects. They
Okay.
can they can aggravate a lot of the motor and non-motor symptoms that Parkinson's patients see. For instance, some of the major side effects are dry mouth, dry eye, which most Parkinson's
Oh.
patients already have issues with.
Mhm.
It can cause constipation, which they almost all have that issue.
Mhm.
It can cause confusion. It can aggravate prostate issues. It can cause, if you're predisposed to hallucinations, they can aggravate that or worsen them. So, and in addition, they also have some overt contraindications. For instance, if you were dealing with gastric delay, or a urinary hesitancy, if you had a form of what they call narrow angle glaucoma, untreated narrow angle glaucoma. These are complete contraindications for the use of this class of medications for these patients. So they definitely have some issues. And then over 20 years, certainly they've been used in Parkinson's patients, some quite successfully without having to deal with those issues. But you don't know. You never know if you're going to be the one that's going to have those type of issues.
Right.
So that's been what they've been dealing with for a long time. And the major symptoms that we're talking about are going to be urgency, frequency, urge incontinence, and nocturia. Nocturia is that term we use for getting up in the middle of the night, which I can tell you straight up is probably the most common of all, especially in Parkinson's. Probably almost 90% of patients will experience or are experiencing nocturia. And just by definition, they usually say that if it's more than once that you're getting up in the middle of the night, that's really considered nocturia. I guess they give you one freebie. You're allowed to get up once, but if
Yeah.
you get up twice, you now have nocturia.
Well,
Um,
and can I interrupt real quick? Probably half of my clients falls when they do have a fall happens when they get up at night because they're tired and they're weak and they're not, their medicine, they're not, high in their, all that other stuff have an effect. So that I just had an aha moment when I'm thinking, this is a big deal.
a major concern, and you're absolutely right about that. And it's not only is it the most common of all the OAB symptoms that we see, it's also the most difficult to treat.
Right.
And the reason for that is just getting up in the middle of the night is not only just about Parkinson's. There are many factors that contribute to that. Um, there are some patients that have nocturnal polydipsia. This is where they generate more urine at night. Certain diabetics are known for this. People with sleep apnea have this problem as well. So there are other medical conditions,
Mhm.
circadian rhythm changes. Parkinson's causes a decrease in our sleep hormone, melatonin. This changes our whole circadian rhythm for a lot of patients. They have these sleep issues. They're up half the night anyway
Right. So
because they don't sleep well. So the body can't figure out, where are we? Are we in the daytime, or when I should be producing a lot of urine, or am I at night? So
right.
there are multifactorial things that contribute to nocturia, which makes it much more difficult to treat. And of course, the ultimate consequence of that is that full risk when that patient is getting up at night and going to the bathroom to relieve themselves. Some patients have solved that. There are undergarments that some patients use. Some patients have a bedside commode, which is a great option as well. They don't even have to walk to the bathroom. Just because you have a bathroom in your master bedroom, it's that walk to that
Mhm.
bathroom that can be dangerous for you. So there are ways of getting around it, but it's certainly the most annoying, and it really can be the most dangerous, because if we do have that fall, and we've talked about, the consequences of a fall for any Parkinson's patient
Right.
can be bad.
Yeah. Thank you.
Now, the other factor I wanted to just point out on these anticholinergic drugs that I mentioned, some of the more recent studies are suggesting that with long-term chronic use, and let's face it, we don't cure overactive bladder, we treat it symptomatically. So if you're going to go on these medications, more than likely you'll be on them for a very long time. But some of the new studies are suggesting that these drugs have an effect on cognition, these
Mm.
anticholinergic drugs, which here again is the last thing in the world a PD patient needs. Cognition issues are inherent with Parkinson's to begin with. So we really want to add another drug that can hasten that is really problematic.
Right.
One of the drugs of those six that seems to be better than the others as far as its effect on cognition is the one I mentioned last, was trospium. Its brand name is Sanctora. This drug does not seem to cross that blood-brain barrier. Again, that's something we've spoken about in the past. When we take medications, they would like to try to get up into the brain, and the brain is very selective on what it allows into the brain. So trospium is a very large molecule. It has solubility parameters that are not conducive to get absorbed into the brain. So if it never gets into the brain, it can't really affect memory and thinking like the other five in that category. And it seems to stay mostly in the periphery, which is a good thing. So out of all six of them, that's really the only one as far, it still has all the other side effects, the dry eye, dry mouth, constipation, all those other things that I mentioned. It's just that it's devoid of that side effect as far as affecting cognition. So that might be a starting point anyway for some patients where cognition may have be a concern for them.
Right. Right.
Now, moving past, I'm sorry, did you have something else?
No, no, I just real quick, I do, because I really do want you to get to what you're going to get to next, because that one is the one that piqued, everybody's interest the other night.
Yeah.
And then also there was more discussion afterwards about what you're about to bring to light. But you did say something, and it can be now or it can be later, about when you take, let's say this is the drug that you discuss with your doctor and it's what you should use. And will I take this drug, and will tomorrow I be able to sleep through the night without having an issue?
Right. Yeah. So onset of action, timeline for all of this, right? Good question. No, that's not going to happen. So typically, it takes about 2 months for these drugs to really reach their peak. And I ask everyone to be patient with them because, as I said, they are effective. But like everything else, it doesn't happen overnight. So, as a general rule, I would think that a lot of urologists would initiate the medication and then follow up with you in about 2 months, ask you to come back for a follow-up appointment in about 2 months to reevaluate it. Mainly because if you're on a drug, or particularly one of these drugs for overactive bladder, and you've been on it for 2 months, and then you come back into the office and you say, Doc, I really haven't seen much improvement at all. He's going to say, you know what, it doesn't pay to keep you on it any longer. If you haven't seen results with the drug in 60 days, the likelihood of you seeing it, if you stayed on it for 3, 4, 5 months, it's probably not going to get any better. So that's why they generally pick that 2-month window to come back to the office to reevaluate the effectiveness, because it does take that long. It's got a lot of work to do once you swallow that pill. It just doesn't happen overnight. There's a lot of changes that it has to make in order for you to reap the benefits of it. So just please be patient with it. Don't rule it out after 10, 12 days. You really need to stay on it for those 2 full months before you can actually honestly say it's not doing anything for you.
It's good advice. Good advice.
Now, that leads me to the next group, which is a little bit different and newer. Like I say, these drugs, these anticholinergics, have been around for 2 decades. There is a new class of medication, relatively new, that's being offered. And this class is called the beta-3 agonists. There's only 2 drugs in this class, and they really have kind of changed the entire concept of treating, not only just for a Parkinson's patient, but anybody can use these as well. The first one that's out there, the older of the 2, is a drug called Mirabetrix, or Mirabegron is the generic name for it. This came out, I think, around 2012, 2014, somewhere in there. It didn't, at least at my end, in the pharmacy end, it never really jumped off the shelf as a top 10 drug. We used to just kind of dust it off on the shelf periodically because we didn't really see a lot of movement. But then I think what happened is that maybe a little different marketing strategy, or their sales force started pushing it a lot more, and it did become pretty busy prescription wise. The reason being is, number one, these drugs have no effect on cognition. They don't cross the blood-brain barrier. They don't get into the brain at all. So that was a huge perk. Number two, since it's not an anticholinergic, it has none of the side effects that we spoke of earlier. All the dry mouth, dry eye, constipation, hallucinations, all of that stuff. And thirdly, it has no contraindications, unlike the anticholinergics that had urinary retention, gastric retention, and narrow angle glaucoma. You don't have those restrictions with these drugs. So right away off the bat, this is going in the right direction.
Mhm.
And of course, they were effective and are effective. The first one I'm talking about, Mirabetrix, it comes in two strengths, a 25 and a 50 milligram. It's taken only once a day. And I like the fact of the two strengths because it enables the urologist to give some titration doses. Go slow and low. One of my favorite mantras,
Mhm.
I always think that that's a great way to approach things. Start off on a 25. You can always kick it up to 50 if you have to. And again, we're still talking about that same 2-month time frame, just like we were with the other class. That onset of action did not change here. The only little downside with the Mirabetrix is it may play a role in elevating blood pressure. Um, so that would be something that would have to be monitored. Now, for some patients with Parkinson's, they have very low blood pressure. So for them, this could be an advantageous side effect. But for others who are dealing with either constantly high blood pressure or some patients have huge fluctuations in their blood pressure, that might be an issue. I'm not necessarily saying it's a deal breaker, but it would have to be monitored pretty closely, both on the physician side and possibly even at home with some
Mhm.
home monitoring. Um, and the other thing with the Mirabetrix, just a side note, is that the tablet cannot be crushed, chewed, or divided in any way. So that might be a small problem for patients with some swallowing issues. The other drug in this class is a drug called Gemtesa or Vibegron. That's the newest one. That came out, I believe, in 2020. And that is a nicer feature, kind of a second generation of that, because it got rid of the side effect of high blood pressure.
Oh.
And so that, with the Mirabetrix, we had to be cautious of that, but the Gemtesa does not seem to affect pressure at all. So that's really a nice function that they were
Mhm.
able to eliminate from the previous generation. The other thing with Gemtesa is it is available only in one strength, a 75 milligram. Again, it's taken only once a day, so it really doesn't increase your pill load dramatically. It's just a once a day dose, can be taken probably any time of the day. And the nice feature about this one is that you can crush the tablet or break it up if necessary, put it in a little applesauce. So
Mhm.
here again, for patients with swallowing issues, that might be the better choice. So it seems like, why isn't everybody doing this?
Absolutely.
Why do we even still have the other class of drugs? So
Mhm.
it's almost too good to be true. Well, of course, as luck would have it, there are some issues with trying to get the drug. Not that there's an availability problem, but there's an insurance issue. Unlike all the other 6 anticholinergics that I mentioned, which have been around for so long, all their patents have expired, so they're all available generically and they're extremely cheap. And insurance companies love cheap. So,
Mhm.
unfortunately, these two drugs that I just mentioned, the Gemtesa and Mirabetrix, they are not available that I know of generically. That's for sure. So you're only dealing with a brand name drug. As a result, right away for a lot of insurance companies, if they even cover it, it's going to be certainly on your highest level copayment. It's not going to be cheap at all. So that's going to could be an issue for some patients. I've heard patients tell me that those that were able to get it were paying $75 copayments, which on the surface, it doesn't seem like that's too bad, but you have to factor in these patients are on multiple other
Mhm.
medications as well. So when you factor that into maybe 4, 5, 6, 8 other prescriptions they have to get every 30 days, that $75 adds up to be quite a bit. That's a hit. And then, of course, we have the situation where the insurance company has refused to pay for it entirely, and then the patient wants to go out of pocket for it. So I can tell you this, the Mirabetrix would probably run you close to $400 a month if you had to pay out of pocket for it. The Gemtesa would be a little bit more, about closer to 500, which is really almost cost prohibitive for
Right.
everyone. So
Right.
what happens, time and time again, and I've seen it many times in the pharmacy where you'll walk in and you'll hand me a script, for instance, from Mirabetrix, and I'll go to process it. And of course, the insurance company denies it. Some of them have what they call step therapy, where they want you to try the other medications first because they're cheaper.
Mhm.
And if they don't work, we might be able to pay for this. But then, I have to call the physician and I have to get him on the phone, and he's not happy with that at all, to let him know that the prescription you just wrote, it's not covered. So then there's this back and forth of, well, what is covered? And let's try this, let's try that. And you may process things 2 or 3 times until you find the right one that's covered. So unfortunately, the doctors then at that point say, you know what, I'm not even going to write for this anymore, because every time I write a prescription for it, the pharmacy or the patient calls me back and says it's not covered. So that's a huge problem. Now, I did speak with some people in the audience the other day that dealt with this firsthand. Some were very fortunate where, like I say, they did get the Mirabetrix covered for $75. And understand, on their particular plan, it was 75 for that. But normally they only pay like a $10 copayment if it's
Mhm.
the drug that's on their formulary, but they got whacked for 75 because this wasn't on their formulary. But nonetheless, for them, that $75 was worth it and everything is
Sure.
working fine. But for some others, they had to actually kind of fight for it. One of the women were telling me her and her husband are on TRICARE. There was an issue with that it wasn't being covered. And she reached out to the company, and they went back and forth, especially if she could show, or the doctor could show, that she's not a candidate for the other medications. And quite honestly, if she has Parkinson's, she really is a candidate for not having to use those. So the
Yeah.
doctor was very good with that, reached out to the insurance company. They got what they call a prior authorization, and she was eventually able to get it covered. So my advice to the patients are, look, if you're in that situation and you don't just give up the ship because you hear the word no the first time. Reach out to
Mhm.
your insurance company. Some of them have protocols where you can argue that, and get certain documentation from the physician sent over to them, a diagnosis or a proper diagnosis code, or a reason why the doctor feels that this is essential. Just to put things in perspective, cost-wise, going back to those 6 anticholinergics and how cheap they were, if, for instance, one of them was oxybutynin, you could get a 30-day supply for that in Publix or CVS or any of those for like $10 or $15 for the month. So compared to 500 for
Right.
Gemtesa. So you can see why right away the insurance company is going to have an issue with that. They would much rather have you pay for the oxybutynin than the Gemtesa because of that.
Um,
Finally, I'm sorry, go ahead.
that's okay. No, when I guess just the advice, like you just said, is to just don't give up. And it seems like there's a lot you can do on the back end before you have that, moment at the cash
Absolutely.
register.
You
You know,
can.
it's not, so that's really neat to know that there's a lot you can be proactive even prior to the prescription being prescribed to you.
Sure. Now that they know the names of these two drugs,
Mhm.
before they even go to the doctor, they can get on the phone with their insurance company and say, look, I'm on my way to the doc. I'm going to ask him to prescribe one or two, either of these. Would either
Mhm.
of these be covered? And if so, what would my copayment be? And if not, would they be covered if the doctor filled out a prior authorization request? Um,
Yeah.
always ask about that prior authorization, because that's important. That sometimes they're not going to be forthcoming with
Right.
that information, but ask and say, look, if I can get a prior authorization from him, would that help my case at all as far as getting it? So sure, definitely
Yeah.
doing some work beforehand is important too.
Perfect.
One other thing I wanted to mention that I didn't get a chance to talk about in the class on Friday, two things that, we spoke about the drugs, which of course is kind of my thing, but I wanted to let people know that there are other options. Urologists, they have a lot of neat tools and tricks that they can help you with these overactive bladders. For instance, there are non-pharmaceutical approaches to treating this. A lot of behavior modification, a lot of exercise therapy, keeping a log of the issues, that when you go, how much, the volume, measuring how much is coming out with each stream. These are very good techniques, and very often are first line treatments before they delve into the drug treatment. They would rather see you try some behavior modification techniques. And some of them, depending upon the severity and the level of your issues, can be very effective. So
Right.
that's one option besides drugs. The other option that I don't have much dealings with, although I guess we could look at it as a drugs, would be Botox.
Mhm.
Um, we see Botox being used a lot in Parkinson's for other reasons. I've seen it used for salivary injections for people who are drooling and having issues with that. And we're mostly familiar with using it. People use it around their eyes for crow's feet and whatnot. That same Botox, the urologist can inject that into the bladder. And from what I understand, with the procedure it's an in-office procedure. It only takes 5 or 10 minutes to do. He'll make a series of shots of Botox in the bladder, on the bladder wall. And what Botox does is it prevents that premature constriction of the bladder, and allowing it to stay more relaxed and be able to accept more urine, and will cut down on your frequency issues. From what I understand, it's a very effective treatment. It lasts about 9 months, about the same time as it does when you do it around your eyes. Every 6 to 9 months, you have to go and get it redone again. But this could also be an issue. And again, it's not first line treatment. It is probably second or third line treatment for those patients who have tried the other options and are not happy with it. Botox may be an option. It does have some side effects, but they're very rare and minimal at best. But it's like I say, according to the urologist, it's something that can be done right in the office very simply. So again, another option for them.
And that's great to bring up, because like you said, many are using Botox for other reasons. I was with a young lady yesterday, and she, with her spastic, crampy foot, it
Yes,
helps,
yes.
and so they're very familiar with Botox. So it's great to even just bring up, to talk to your doctor about it. If the doctor doesn't bring it up first, could it be another area that
Yes,
works well for
absolutely. These foot cramps, this dystonia that they get sometimes, which this toe curling can be very painful.
you? Yeah.
You see it a lot of times, especially in the morning hours.
Yeah.
And you're right. We've seen Botox used for that, and it seems to be very effective. I mean, like I say, it's not a permanent fix. You have
No.
to kind of keep up with it. But for some patients, they would rather that than add more pills to their regimen. They would rather just go every 6 or 9 months and get a shot in the office or something, rather than to avoid adding another pill to their regimen. And I get that. I understand. The pill load adds up pretty quickly.
Sure does. It sure does. Now, um, real quick, I want to go back to when you talked about um, tracking. Now, you said something, and I think maybe just spend another minute on it. So keeping a log, and then presenting it to your urologist, explain that a little bit.
Yeah. So again, not really a drug treatment. So um, what I see them do very often is try to hold out as long as you can, this behavior therapy, this behavior modification, giving them certain exercises. A lot of people are familiar with the word Kegel exercises, to help strengthen those pelvic floor muscles and the core muscles. Now, this is a topic you and I have talked about many,
Mhm.
many times, and I know you deal with your patients at your end. You're always focusing on core strength and pelvic strength as well. And quite frankly, it's so important, more important with Parkinson's, because it can really help two things. Number one, the core strength, which of course would be great for constipation issues. With that peristaltic activity that we have in the lower colon, they lose that because of that's, again, under autonomic nervous system control. So having a good, strong core is going to help that. And honestly, believe it or not, constipation plays a big role as far as the bladder, because anatomically, that large colon sits right on top and behind the bladder. So when it's full and impacted, it's putting pressure on that bladder. Pretty much the same way in pregnancy, you'll see that, right? Where the baby
Yeah.
was sitting on the bladder all the
Mhm.
time. And again, as we mentioned Friday, women aren't, they don't escape this issue either. Men have the prostate issue, but women, because of during their childbearing years, and giving birth and carrying that baby for 9 months weakens those walls in the pelvic floor. So even more important for them, some of their symptoms can begin even earlier than the men because of that. So it's just as important for the women as it is for men to keep and maintain that pelvic floor. But a lot of, and that's part of the non-pharmaceutical approach to these things. And keeping that diary, from what I understand, again, a behavior mod technique, to try to see if we can expand the length of time that we're going. Maybe instead of going every hour, maybe we can try to go to an hour and 15 minutes and kind of log it down and see if that's possible. We don't have control over everything that's going on down there. We can only hold it off for so long. But we can improve that with certain exercises for sure.
Right. Well, and I see that, okay, now I get what you're saying. And I see that as being, one, our brain, since most of it's because the brain likes to see success, right? So like,
yes. Oh yeah.
Some sort of reward in your brain. If you're like, oh, I made it, an hour and 10 minutes rather than an hour, so
yes.
I can see just even like reality is that does affect our ability to go longer. So I gotcha. And then just even tracking that also tracks success, which has a result.
The other added thing to that, Tammy, is of course our fluid intake.
Yeah.
It's going to be a delicate balance because we're always telling Parkinson's, hydrate, hydrate, hydrate. It's just so valuable for you in so many ways, between keeping your blood pressure, your temperature regulated, your constipation at bay. It's so important to keep yourself hydrated. But then on the other hand, we're talking about these overactive bladder issues where obviously the more fluid you take in, the more it's going to have to come out. So trying to, the urologist will help with this, we want to give you just the right amount of fluid, but we don't want to overload you so that you're going even more than you were before. So that becomes a delicate balance that has to be determined. And that's where the urologist will play a huge role with that.
Absolutely. And I would give the advice to anybody who feels like every time I take a drink of water, I pee it out, to actually talk to the urologist, because perhaps it's an absorption of the water issues. So as a fitness professional, I see people who take drinks or drinking water all the time, and they're sweating it out or they're peeing it out, and it's not being absorbed into the body. Now, it's out my scope of practice to tell you why, but your urologist or your doctor can tell you why.
Absolutely.
And that would be something to bring up, because if you're going to drink water and then you're going to go pee it out immediately, there's a lack of that water actually doing what it needs to be doing. So that's definitely, I would say, talk to your doctor about if that becomes an issue.
Yeah. And the other thing too, I had a gal come up to me on Friday, and some patients, especially with OAB, they say, I'm going to minimize, I'm going to cut out all the excess. I'm going to stop drinking my coffee and not so much on my water. And that's probably the worst thing that you can do because of some of the other issues. And she brought to light, she said, that's exactly what she did. She minimized her fluid intake, but ended up with a serious urinary tract infection because she wasn't drinking enough fluid. And then and it was a pretty nasty one. It took quite a number of weeks to cure that, antibiotic wise. And her urologist kind of yelled at her in a kind way, telling you can't do that. You just can't stop putting fluid in because you think you're going to cure the overactive bladder situation. That's not the way to do this. That's not the way to go.
No. Now, in the last couple seconds we have left, I'm going to, Bob had mentioned pelvic floor, core strength. I have several videos on our YouTube channel for pelvic floor and core strength, and I will add more in conjunction with this, so that at home you can do exercises to actually assist in combating urinary issues. But in scope of that, Bob, I'm so thankful. I know the whole entire group and everybody's thankful for your generosity, for sharing the knowledge you have and the time that you give. So kudos to you. I know it blesses your heart. So this is something you feel is a chore, but just know that you are so appreciated.